remember here today, the future is, I think, very bright about early detection and improvements in early detection. We have many new technologies and possibilities for picking up breast cancer at a very early stage. So our goal, Joel and I, we are trying to pick up breast cancer obviously before it's metastasized around the body, and also before it has what we call clonally diversified, made different clones that make it harder for the chemotherapy agents to treat. Okay, so that is our goal in life. Really, I think I would say that we dedicate our life to that. So how many of you have heard of the breast density legislation that's coming out soon? Well, I think it's going to be, there's a federal legislation that's coming down the pike. And I think here in South Dakota in July, there's a state regulation. So that we have come to realize over the years that screening is a lot more complicated than just going and getting your mammogram. And you know, this is where we are sort of moving away from population-based screening to more of a personal screening, because we recognize that everyone is not the same. So that we know when we look at mammograms, every breast looks very different. And we know that every woman has different risk factors for breast cancer. So our challenge is to figure out, given that particular woman, what is the best screening that would suit her in order to pick up very, very small breast cancers. And so we've been doing okay, I would say. I don't think that we've been doing really great on a population-based screening model where we are recommending just mammography, because we know that mammography in certain women is limited. And I think for those of you in the audience, you know that in dense breasts, that perhaps the mammogram's not going to pick up as much as if you had fatty breasts or so. And because we live in the United States and we don't have a national screening program, like if you go anywhere else in the world, okay, you go to Australia, Canada, you go to anywhere in Europe, they have a national screening program where the government actually runs the screening program. And they will send you a letter in the mail, and then you will come in, you will have your mammogram, and so the government sets the guidelines and the recommendations for when you should have this test. We are lucky, I think, living here in the United States, where we don't have a national healthcare system yet, I guess you could say. But so we have societies that issue guidelines. Now, how many people in the room are a little confused about guidelines and when they should get their mammogram or not? Because I tell you what, I'm in the business and I'm totally confused because it seems like magazine cover comes out and says you don't have to get your mammogram until 50, or you only have to get your mammogram every 2 years. And you know, the American Cancer Society comes out with a recommendation. Then you have a body of people called the USPSTF, which are experts in recommending guidelines, come out with a different set of recommendations. So you as a patient, or us as physicians, it's a very confusing time, I think, for recommendations on how to be best screened. So if there's a second thing that you remember from today, it's that screening is simple, okay? It's every year starting at 40. And we here in the United States don't have a cutoff like they have in other countries. In Europe, after you turn 70, you in some countries you're not eligible to have screening. Here, we recommend that you are screened up until you have a 5-year life expectancy. So that's for many women through their 80s. So it's a simple guideline, and it's supported by the American College of Radiology, the Society of Breast Imaging, and also the Gynecologist Society as well. So that is one area I think that has been a little confusing for people as far as screening. Okay, so let's talk a little bit about the research and the exciting work that I think is going on. We are living, I think, in the next 10 years in probably the most exciting time in medicine, because there's two things that are happening that are going to, I think, change the way that we not only diagnose disease, but also treat it. The first thing is we have this genomic revolution going on, and we're able to sequence everyone's DNA. We're able to actually take swabs from people's mouths with very simple tests, and not only look at their germline, their actual DNA, but we can also look at other factors that are called, in the screening world, that are called SNPs. Has anyone heard of SNPs? Okay, it's called SNP, and it's a short word for single nucleotide pleomorphism. And what it means, we all have SNPs, and we have more and more SNPs the older we get, okay, because we've been around longer. And what happens are these base pairs, they change in the DNA. And so they can be in areas that don't code, they can be in areas that code, but we have come to recognize that these markers, as you will, are able to, or at least triage women. There's about 90 or so SNPs that are associated with breast cancer, so that you can assess risk for the individual woman, potentially. So that some women may not have a lot of these SNPs that you can assay for, and you can assay for them in the saliva or the blood. And so they may not need, perhaps, as much intensive screening as other women who have more of these SNPs. So this is a very exciting area, because maybe what we're going to be able to do is sort of stratify women, those who have a lot of SNPs and have more of a genetic susceptibility to developing breast cancer, into more intensive screening programs. And that's one of the things, actually, that my research with Komen is looking at. And I think it's a very, very exciting area to look at risk-based screening as opposed to population-based screening, where you just have one recommendation for everyone. The other thing that comes in is that we have more of a development of risk models that you can use, like the Tyrer-Cuzick, which is a model that you may have heard about. And you can go online, actually, and put in your information, and you can get a risk profile from that as well. And so we've found that these risk models, plus all the genetic information, plus all your breast density, actually can stratify you into whether you're very high risk, intermediate risk, or low risk, or average risk. So there's a bunch of trials that are happening throughout the world right now. One that's happening here in the United States, looking at this. And so it's an interesting way to actually attempt to screen a woman as an individual, because we all know that we're all different in some way or not. So that trial is called the Wisdom trial. You may have read about it. It is mostly in California. It's expanding into the Illinois area, as well as on the East Coast as well. And women appear to like it. They like it, and they like to know what they have the option when they go into the trial to decide, do they want to be screened in an individual way, or do they want to be screened in a population-based way? And the majority of women want to be screened individually. And I think that brings up another very important point, because this has to be a choice, in the sense that, anytime you go and get screened, it is a choice. It's a personal choice for every individual person. So I want to talk a little bit about the new exciting areas on how we can personalize screening. So once we know that you're high risk, we're able to offer other tests other than just mammography. And these days, mammography really means 3D mammography or digital breast tomosynthesis. In the United States, DBT or 3D mammography is rapidly replacing all of the standard mammography. I think it has almost a 50% market penetration. So it doesn't mean that 2D or the old-fashioned mammography is no good, but the standard is that with 3D, you have less of a chance of having a false positive, which means you won't be called back as much for potential abnormalities on your mammogram, which is a great thing because no one likes to get those callbacks and then you come back, you're very anxious, you're worried, and then you get worked up and then you're told that it was nothing and you're like relieved, but it would be nice not to have that period of anxiety. So that's one of the real benefits to me of the 3D system. It does pick up a few more cancers, but the real benefit is in the false positives. But it is the new standard mammography. And I think mammography technique has improved really dramatically from the days, from a couple decades ago when all the randomized controlled trials happened. So we have 3D tomosynthesis for everyone. And then we have other things like ultrasound, or what I call contrast-based tests. And contrast-based tests include MRI, and there's a new sort of kid on the block called contrast mammography. And it's actually a mammogram that you have an injection, like you would for an MRI, and we're able to see the cancer light up with the contrast agent. The benefit of a contrast mammogram is it's cheap. It's done in facilities that have mammography units. It takes really no longer than a regular mammogram, aside from the injection. The risk profile as far as having a reaction from the contrast, it does have a few more reactions than what you would have with an MRI, but they're usually, and they're sort of flushing kind of reactions. We've done, I think, over 5,000 of these cases, and we've only had one case of hives. So it's a fairly, tolerable exam, and it's a really, it has a real potential, I think. So I kind of lump the contrast-based tests in one bucket as our best screening tests. Then we have ultrasound, and then we have, the 3D tomosynthesis. So the density laws that came along because we were missing a lot of cancers with the mammogram. And the reason we were missing them is that it's sort of the density issue. It was mostly in dense breasts. And density is a tough one. And density means, you can't feel density. You have to have a mammogram to know if you're dense or not. And it just means that you have a lot of tissue in your breast, and whether it's collagen, whether it's, epithelial tissue, which is what breast cancer comes from, it means you have a lot more tissue in your breast than in someone who's got a fatty breast. So in dense breasts are kind of a double whammy, if you will. They mask the cancer. So they make it really hard to pick up the cancer because the cancer is the same density usually as the regular normal native breast tissue. The second thing is that women who are dense have a small increased risk of breast cancer. So they not only are at increased risk, but it's harder to pick up the breast cancer. So there's been a lot of attention to women who have dense breasts, and that's why this legislation is happening. So about 50% of women have dense breasts. So so half of us here in the room are dense. Not in the head, but in the breast. Okay. So we need something else other than mammography, okay? And so the easiest thing to do is to do an ultrasound. No radiation. It's easy to do. Every office has one. What is the problem with ultrasound? Ultrasound's better than just doing the mammogram alone. It will pick up about 3 cancers per 1,000 more, but it's not as good as these contrast-based techniques. And the problem with ultrasound is it picks up a lot of stuff you don't want to pick up. So you have a lot of callbacks, a lot of biopsies that turn out not to be anything. And so it causes a lot of anxiety as well, I think, amongst women. So it's sort of a little bit of a better option, but it's really not where we need to go to pick up really small cancer that is there that we want to pick up before it's metastasized, which is our goal. Okay, that's our goal. So the contrast-based techniques, they are definitely sort of the Rolls Royce of our imaging that we have. And the MRI, I'm sure a lot of you have heard of the MRI and have possibly had an MRI. It has been around for a long time, and it has been recommended for very high-risk women who have BRCA1 or BRCA2 mutations. And, but it's not used that much. And even though there's been recommendations out for MRI in these really high-risk women, it's not being used around the country. So we have to ask why. And a lot of times what it is it's too expensive. It's too, it's too much noise. It's too, there are issues, and also not everywhere has an MRI. So what we've come up with is this concept of an abbreviated MRI, which is an MRI that's under 7 minutes. You do it really super fast, you get an injection, and it has been shown to pick up many, many more cancers than mammography in a shorter space of time. So now we have this abbreviated MR that we can do, as well as the contrast mammogram in the contrast bucket. And then we have ultrasound and mammography. So I think what we'll be seeing in the future is that women who have sort of higher risk, whether it's through genes or family history or even breast density, will be getting these contrast-based techniques. Women who are not as high risk, more intermediate risk, will be getting the ultrasound part, and then those who are sort of average risk will probably be just getting the mammogram. So I think this is sort of the roadmap, hopefully, for the future, so that we can sort of reach our goal of very, early detection, because that will help move breast cancer mortality in the right direction. Now, I just want to leave you with, I think, what is really exciting, and with research and what's going on in my area, and that's. Joel and I, we look at images all day long, okay? So, we look, that's what we look at, is pictures, you could say, okay? So we go to work, we look at pictures. And there's really good evidence now to show that a picture has a lot more information in it than we can see with the naked eye. So that we're able, with image analysis and artificial intelligence tools, to actually mine data from the images to be able to predict who is at high risk for breast cancer, who is going to respond well to therapy, and who is not, and who is, has a higher chance of a relapse. So there's information. It's almost like we have a blueprint of our breast, if you will, right? And it shows us all of our history, all of our, how, if we've lactated, gone through lactation, we've had pregnancies. It shows us what is going on, I guess, in a very molecular way. And so the research that we're doing right now is looking to see, can we, through artificial intelligence machine learning algorithms, be able, from the image alone, to actually help predict in a sort of an algorithm model. So there's very, very interesting data that's coming out that shows that these algorithms can be even better than these risk models that we currently do, because it's artificial intelligence. I'm just joking, but everything's, we're going to be saved by artificial intelligence, it's a powerful, very powerful tool. And I think, that's where the future of the study is looking at the information that is contained there within, and being able to hopefully direct us to what needs to be done next for each individual woman. So I think that's kind of the end of my screening kind of talk. The take-home messages are every year, starting at age 40. If you are at higher risk, you may need to start in the age 30, in the 30s. And that is if you have a first-degree relative, a mother or sister with breast cancer. You need to start screening 10 years before they were diagnosed. So if you have a mother who was diagnosed at age 42 with breast cancer, you should be starting to screen around 32 every year. And if you're high risk and you meet those high risk criteria, you may actually need to be screened with a contrast-based technology. That's it. I think, open for questions. Okay?